So I would like to start with the first speaker. May I introduce Dr. Jong Chung Kim to present how to use AI-QCA in the Cath lab, the case-based lecture. Dr. Kim.
Yeah. Okay, thank you, Chairman. I try to save the time. Today's I'd like to talk about the AI QCA assisted PCI. As we know, that there are two intravascular imaging modality and OCT and IVUS. So since 2015, we have pivotal randomized trial regarding the image-guided PCI, and among them, the Renovate trial and the IVUS HS or Occupy trial demonstrated that the benefit of the image-guided PCI in terms of the hard endpoints such as the cardiac death and the target vessel myocardial infarction. And the last year, image-guided PCI for the complex region in the CCS patients was class 1 indication on the European guidelines. In this year, American guidelines announced that the image-guided PCI for the left main disease and the complex region is class 1 indication in the setting of the ACS. Even though there are guidelines and the strong evidence of the benefit of the imaging guidance, but clinical benefit of intravascular imaging are less well established in less complex region. Furthermore, its global use is likely to remain limited, as you can see, because of the various practical, logistic, and economic issues. So in the real-world practice, it's actually angio-guided PCI has become the de facto strategy at this moment. So theoretically, angiography-guided PCI refers to the QCA-guided PCI. So a couple of years ago, GUIDE-DS is a multi-center randomized non-inferiority trial conducted by Assam Medical Center, demonstrated that QCA and the IVUS guided PCI showed the similar rate of the target lesion failure and the 1 year and the key clinical endpoint among about the 1,500 patients who requiring DES implantation. However, there are so much complicated QCA-guided PCI protocol in the GUIDE-DS trial. So I think that the result was optimal, but protocol was not be optimal, I thought. So actually, in the real-world practices, angiography-guided PCI seem to be the same as the eyeball-guided PCI and the visual estimated guided PCI, or sometimes experience-based PCI. So it should not be happen, but sometimes the eyeball-guided PCI with less experience lead to this kind of disaster, as you can see. Operator would not put the stent of the 2.75 millimeter diameter if the AI-QCA provided accurate information such as 2.07 millimeter in the distal lumen diameter. So we conducted the flash trial regarding the AI-QCA assisted versus OCT-guided PCI. So AI-based fully automated QCA offered the real-time automated quantitative analysis of the angiography without requiring additional time in the cath lab. So among 400 patients with coronary artery lesion undergoing stenting, we randomly assigned to the AI-QCA assisted PCI group and the OCT-guided PCI group. But primary endpoint was not the clinical outcome, but the minimal stent area by final OCT in both 400 patients. So in the flash trial, relatively simple lesions were included. So complex region, including the left main region and the CTO region and the graft region and the requiring two stenting bifurcation region were excluded. Regarding the stent diameter and the length, so we recommend the select of the stent size and the post-stent final NC balloon size up to 20% larger than the distal reference diameter. And regarding the stent length, and it was chosen based on the lesion length provided by AI-QCA. So this is the primary endpoint, and the minimal stand area was 6.3 square millimeter in the AI-QCA group, and the MSA was 6.2 square millimeter in the OCT group, and it successfully achieved the non-inferiority of the AI-QCA compared with the OCT. Regarding the OCT-defined endpoint, there is no significant difference except for the malposition. Malposition occurred more frequently in the AI-QCA group. However, the mean MSA in the malposed segment was 8.4 square millimeter, which was the acceptable, and no malposed segment had MSA less than 5 square millimeters. But AI-QCA assisted PCI is just the beginning. We need more evidence and the data in terms of the safety and the efficacy. Nonetheless, the FLASH trial is the first study to suggest the possibility that AI can help the physician in the real time in the treatment area. So I'd like to show how I perform the AI-QCA assisted PCI in my daily practice. It's a 70-year-old gentleman complained of effort angina, and the angiography showed that the severe stenosis in the middle RCA and the intermediated stenosis in the distal RCA. Generally, when angiography-guided PCI is required, operator plan to in advance where to insert the stent. In this case, in this, how can I backward? Yeah. All right. In this case, I do not want to put the stent over the bending portion in the middle RCA. So after the angiography, you will see the program automatically select the optimal frame to obtain the AI-QCA. Then my colleague just check the frame and click it on to get a AI-QCA. We can see the immediately proximal and the distal reference lumen diameter and the lesion length. And as I mentioned before, I'm already had a plan to put the stent in not over the bending portion. So we could move to the distal reference area where I want, and the MPXA program immediately showed the QCA data. So AI-QCA provided 2.92 millimeters of the distal reference lumen diameter and 22 millimeter of the lesion length. So I selected 3.0 by 22 millimeter stent. Then I could put the stent in where I want to using the AI-QCA GPS. Post-dilation was achieved with a 3.75 millimeter NC balloon at up to 22 atmosphere, and you can see the final angiography on the right panel. Regarding the distal RCA lesion, QCA showed the 54 stenosis, so we performed the FFR, and the FFR value was 0.9, so we deferred the stenting. So let's move on to the next case. It's a 57-year-old gentleman complained of effort angina with a history of the DES implantation and the DCB treatment. Angiography showed the patent of the proximal to middle RCA stent, but showed the severe stenosis in the distal RCA with the slow reduced the flow, and the severe stenosis in the DCB treatment size in the middle RAD was observed. So AI-QCA could immediately give the real-time information of the lesion length and the reference lumen diameter in the distal RCA lesion. So with this reference, I performed the AI-QCA assisted PCI with drug-coated balloon of the 2.5 millimeter after predilation using the 2.5, the scoring balloon. So final angiography showed that good distal flow without residual stenosis. So in the RAD region, the AI-QCA showed 51% of lesion stenosis. So physiology assessment was done. Its RFR showed 0.83 and the FFR was 0.66. With the real-time AI-QCA PCI with 2.5 by 28 millimeter DES implantation was done. And I'm very happy to get a successful AI-QCA assisted PCI for the multivessel disease. So now we are using the AI-QCA for our fellow to the understanding the promote the PCI during the angiography guided PCI or even the image guided PCI. So this is my last slide. Is in the near future, I hope that if the image-guided PCI is not feasible, AI-QCA assisted PCI could be a good option. Thank you for your attention.
Thank you and congratulations, Dr. Kim. So I would like to ask our analysts here and our colleagues here have any comment or question about the presentation. Yeah. Please.
Thank you, Dr. Kim. Like I said, it's just a beginning, isn't it? It's very interesting. Can I ask you, this AI-QCA? Well, sorry. The AI-QCA, is it something that came with the equipment, or is it a model that you developed yourself? The AI-QCA that you used for your flash study, was it a model that you developed in your hospital, or did it come with the angio equipment? Is it a new model? Did you create the LLM and the AI model for the...
Actually, I have no idea how they developed that program.
It's commercially available?
Yeah, but it's now is that they permitted the commercial program in the South Korea, but it's that they try to the negotiation with this government at this moment because it is very sensitive. There's a cost. Yeah, but it's they try to expand the use of the Medipix is MPX program in the East Asian area. But at this moment, is that this is not commercial program.
Oh, it's a dedicated thing. Oh, so only you had access to the model.
Yeah.
Do you know if they used OCT for developing the model, or just, I mean, to create the QCA, to create the sizing, just based on angiograms, or did they compare with any imaging to create the model?
We try to perform the further analysis. And the subgroup analysis is a flash trial because we have almost 400 OCT data in the AI-QCA data and the OCT guided PCI group. But it's that we need more time to analysis of that because it's after we successfully achievement of the analysis, the OCT, we can compare exactly how we perform the AI-QCA is based on the OCT.
Yeah.
Yeah, but we need more time.
Fascinating. Thank you.
Yeah, thank you.